Hello there. So my name is Dr. Chris Prue, and I'm a director of education for a company called Digit Soul. I'm also in private practice, and I've been practicing now for 20 something years, about 25 or so. I am a chiropractor and did my PhD and master's in exercise science biomechanics. Was an athletic trainer for about 15 years as well. And so I've worked in various settings and have really implemented spinal distraction decompression in all of those settings. And it has some interesting application, and I'll pull out some of those as we go through this discussion. Second off, thank you to Dr. Lallier and the crew at DMR for giving me the opportunity to speak to you, and thank you to all the participants here listening to me speak. And hopefully I'm going to give you maybe some insight, maybe some things you already know, maybe some things that you might be able to implement or consider or do things a little bit different. So as you can see, I entitled this Spinal Traction, Decompression, and Distraction. Same or different, and why use it? If you're in this session, then you kind of already have an idea of why that is, and that the fact that you already are using it. So this is really designed to give you a little bit more background into the integration aspect of it, and potentially why we use it or why we seem to find it successful for us. So basically, if we think about, how we've been treating the spinal column, and we've been doing this for a very, very long time. So even when we look at the historical perspective of spinal distraction or traction or decompression, we'll get into some of the name variations here in a moment, but that's actually been around even for 4,000 years. And we've been treating, spinal conditions for even longer than that. We've evolved, hopefully, in the way that we actually approach our patient care, more so from the patient-centered or whole patient perspective. And so what's interesting when we look at some of the physical agents are how we address the patient as a whole, and understanding this is just one part of one example of the whole integration in the patient care aspect. But knowing that, the things that we can use that actually influence all of those components regarding the patient condition, potentially the better off. Least of which we get a little bit more bang for our buck if we can sort of cross over and overlap. So, for example, when patients have a chronic pain condition, if they've had it for longer than 3 months, they tend to get to a stage where, they have a little bit of apprehension. And that's why it's important to make sure that we understand what exactly it is that we're doing to them, and we explain it to them appropriately. But also, if we minimize, the amount of excessive things that we have to do, then that's even better. So that's understanding what it is that we need to accomplish and understanding the impact of each one of our applications or approaches, and making sure that there is an integration level to all of the things that we're doing. And again, I'm preaching to the choir here because that's exactly what the DMR method is it's creating that level of integration. As I mentioned, it's been around for a long time, and so this is one of my favorite movies. If you've ever heard me speak before, it's popular slide, and I seem to be able to work it in pretty much everywhere. But I joke because, in the movie Braveheart, when he's being tortured, ironically, I joke that, if you watch the film again and look real closely, because it almost looks as though he's smiling a little bit, and I call that the joke because in that movie, because he's not a large man, but he's riding large horses and he's wielding a sword and he's fighting on horseback, so obviously a lot of compressive forces. And I joke that he had a disc herniation, and so he was actually, during torture treatment, at least in the filming aspect of it, he was receiving decompression therapy. And the reason I bring that up too is a lot of the things that we do in the physical agents realm, they sort of fall along this continuum, right, where they came from someplace else, and partly it's either physics or electricity, whatever the case may be. There is this continuum, and that's why when we think about the name, for example, if I say traction to some of you, like my first experience with traction was it was very archaic, and all these old leather straps. I mean, it looked like we were getting ready, to send someone off to war in an old, World War I plane, or World War II plane rather. And the way that, it was so uncomfortable, and basically we treated everyone kind of the same. And so that resonates with certain people, especially when I'm talking to other clinicians, and I mentioned traction. Well, decompression is, it's a more modern term. It's been around for a while, for a few decades, but in the grand scheme of the age of spinal distraction, it's pretty young, but it has a different connotation to it. And actually, a lot of people relate that connotation to, better outcomes. And I have had patients that swear they've been someplace else, like, oh, I've had that done before. Well, sometimes it's actually about the approach or how you use a tool, right? So I promise you that, a paintbrush in my hand is very different than the paintbrush in the hands of Leonardo da Vinci, right? Or somebody like that. So sometimes it's the way that we approach it, or potentially use that. And I threw out another term there called distraction. So think of spinal distraction as sort of this all-encompassing term that includes things like traction and decompression, right? And even flexion distraction for those of you that might practice chiropractic or something like that. So that's the all-encompassing term. And the reason I use that a lot too is it sort of opens up the door to having an open-minded discussion. And that's kind of the reasoning, behind that. But, keep in mind that we've been having this conversation for over 4,000 years. So I find it somewhat comical when someone, dismisses it that quickly, when something that's been around, and they'll quote a couple pieces of literature that may or may not be relevant, but there's always information on both sides of the coin. So when we think about the overarching concept, and it almost doesn't matter what kind of practitioner you are, that we have certain things to take into consideration. So when we think about the spinal stabilization system, that's sort of the underpinning of how we develop our methodology when we are managing these conditions, and we think about especially that neuromuscular unit and how that integrates between the spinal column and the spinal musculature, as well as the dynamic and even the static aspects of looking at, stabilization and the relaxation part. We always think about, stimulation, stimulation, stimulation. Well, what about relaxation, right? And I say this, to people a lot. I'm like, listen, you're standing upright all day long, and then you finally get to sleep. And yeah, maybe get to sleep for 8 hours, and it seems like that's a long time, but relatively speaking, just the pure absence of the gravitational pull, that relaxation process is rather elongated. It also matters on the quality of sleep that you get. So it's important to sort of take that into consideration and look at, decompression and certain aspects of spinal distraction as sort of that accelerated, method. And in fact, that's actually what got me involved in the implementation. When I was first approached and we're talking about traction, it was the same thing that I just referred to. Was in my mind, I'm like, you know what, almost 30 years ago, I started using that, and it really wasn't all that successful, at least the way that we approached it. And so in that moment in time, so I was at university, and so I was working with mostly sports people. And I said, listen, I don't really need a disc sucker back or inner, so to speak. I said, I need something to help me manage, these conditions and get people back on the field. Because ironically, one of the number one major reasons that an athlete's going to miss an event is actually because of low back pain. And so I said, if I could really do something to address the neuromuscular aspect of it, I said, then we can talk. And lo and behold, this really does help to address a major component of that, which if we think about the essence of what we're doing in pulling, in that axis, is, people call it stretching. I just call it displacement. right? Because if you really want to stretch it, stretch anything, you go to the opposite direction of its muscle activation, right? So if you're looking at the extensors, then you should be going into flexion. And when you go into forward flexion, I mean, you can separate those components to a much greater degree than you can with separating during decompression. So it's not really just the distance at which we create vertebral separation and therefore impart that amount of separation onto the tissues, because the tissues actually have a lot more extensibility to them than that. So it's kind of what else is going on, and that's really what we're here to talk about. What is in a name? I've kind of gone over this. So traction basically was kind of the old thought process. My poster just shifted. The old thought process. But we need to take that into consideration, because if we are dealing with provider payers, and there's a specific code 97012, and you fall under that specific, description, then you kind of got to take that into consideration. Or if you're doing something different and you want to bill at 97012, you need to make sure that whatever it is that you're doing falls under that criteria of that specific billing code. Now, distraction is what makes it sort of outside of that, and as well inside and encompassing, right? As we said, that's kind of the overlying. So typically when you look at the definition of that particular code from most payers, it usually means a relatively high force. And again, that is more the archaic way of thinking about it, versus decompression has two components to it. It's a more modern way of thinking about it, as well as the intentions and the interactions of what it is that we're trying to accomplish. Historically, when it first came out, it was more about creating that negative intradiscal pressure that results in the reversal of a herniation, a protrusion, or something like that, which, as we will discuss, it does that very, very well. And then we might even discuss, does it actually stay and whether or not that's completely important. But anyway, so decompression, sort of has a different definition to it, which actually does not fall under the hospice of 97012. And that's why, we may bill it differently, and potentially for good reason. Now, all of these have some indication that we're moving the forces in the opposite direction, right? And so it's the devil that's in the details in terms of some of the intent. So some people say, well, is there such thing as just a decompression device? And the answer is potentially. You could call it that, but all of these devices fall under the same clearance or approval from the FDA, which is mechanical traction, and that's just the term that was used because it's been around for a long period of time. But it really also has something to do with the intended use. So in the case of decompression, creating negative intradiscal pressure as an indication, that's not really covered under 97012, and therefore people won't pay for that. Also, people have used decompression and build certain other codes, and I won't spend a lot of time on that because that's been a while. But in any event, there are different ways that we can actually accomplish some of these things, and that's why it's not just in a name, it's also in the intent. It's also how you use the tool. Again, there's no possible way I'm ever going to paint like Leonardo da Vinci, but I think of us as clinicians when we apply something like decompression. Just when someone says that to me, it means they have a thought process of using this device to another level, which is different than, putting that same device in the hands of someone who consistently calls it traction. Right? And even when we look at some of the older terminologies, so I keep this in my presentation. So this was from a textbook I used when I taught therapeutic modalities. And gosh, I want to say that was published back in '97 or something like that. And so Chad Starkey was the author of this. And so again, using traction and distraction as almost sort of these interchangeables, and that, it's actually the opposite of compression, which is decompression. And so you can see where some of these terms, kind of get a little bit jumbled and mixed up. So it may have something to do with how people interpret that, and why, it may be worthy of a little bit further description. In the case of decompression, most of us have come to utilize it as a descriptor for creating negative intradiscal pressure. Now, it's not an unusual concept. I mean, if something is typically under a compressive load and then you remove that compressive load, internal physics are going to change. And then when you actually create decompression, which physically speaking is really the negative of compressive forces, right? It's kind of like saying acceleration or deceleration. The effects due to gravity are only listed in either positive or negative acceleration. When you're going with it, it's positive. When you're going against it, it's negative. So similar here is that, we are actually taking the reduction of the compressive forces and going to the next level, and we're actually further creating, separation. And again, I tell people, I'm like, listen, this is not a new concept either. And I ask them, and when people give me pushback and they're like, well, what's the point? Well, the point is, if you're a manual therapist and you like to do manual therapy, I mean, the most basic form of manual therapy and mobilization, right, is like a grade 1 in the long axis, which is a form of decompression, right? And so that's why we pull on stuff. It's one of the most earliest phases of a manual therapy or decompression, really soon after. Why? Because it's creating a 360-degree influence on those tissues. So typically, when we're doing long axis traction, long axis distraction, long axis decompression, whatever you want to call it, we're not overloading or asymmetrically influencing the tissues in the same way that if we were trying to go to end range of a joint structure. So it's very different in that regard, in terms of how we're overloading, because we're actually kind of doing that three symmetrical phase. So we're trying to influence in a 360-degree fashion, right? Which is very different than doing like flexion distraction. And that's why when you look at these coordinated movement patterns, that basically anything that moves the spine is going to provide some form of decompression. It just depends on the primary vector, right? So in decompression therapy with the devices that we're using, that is the primary vector. And I always use the example of, like, again, using a long axis distraction. Can I go into flexion or extension and perform and get distraction and decompression? And the answer is yeah, but it's going to be asymmetrical, and you might actually get compressive forces on another portion of that particular articulation. So long axis distraction is a little bit different than some of these others, but also take into consideration that, it's not necessarily at end range. And that's where, again, I try to get people to think about, well, if I'm not overloading a tissue at end range, does that give me some other opportunities? And it'll go back to, some mobilization grading criteria we'll talk to in a moment. So what do we need to deal with? Well, to get to that disc, there are some other tissues that we need to get through first. And first and foremost, it's the musculature, right? And why I tell people, it's so important, first and foremost, that you get people to relax. Because relaxation means that there's a decrease in the activation of the musculature. Now, you tell people to relax, and they can relax, but remember that with patients, nociception in and of itself can create a elevation to the sympathetic nervous system. And even if it's not conscious, on the subconscious level, even muscle spindles can be active, not spasmodic, but more of that hypertonicity. And that's actually going to be resisting, the direction that we're actually trying to pull people in. So let's look at that whole motor unit and take all of those things into consideration, because it also has indication as to the tissues that you're potentially dealing with. So for example, I use decompression, lumbar decompression, on people that have hip problems. Why? Because we have a muscle, a very large muscle, the psoas major, and I think I'll show you a picture here in a moment, that crosses the hip joint, obviously, but it attaches to almost every segmental level of the lower lumbar spine, right? And we can also look at some structures up here in the cervical spine that otherwise you would think, oh, well, it's a multi-axis joint, or a multi-axis muscle, I should say, and why it's going to be impacted by doing something that otherwise people consider either just lumbar or just cervical. So what's interesting is we have a multi-influence on that. What's also interesting is when we do that, we create a reduction in the motor neuron excitability within that pool, right? Which is sort of that loop, and we think about it. Yeah, we can look at it from the segmental level, but more so from the plexus level, right? So like the lumbar plexus, for example. And what do we get from that? Well, we get anybody who drinks from that pool is going to be suppressed. So what's interesting about that is people that are hypertonic to begin with, we actually suppress that and we normalize that level of motor neuron excitability, which is kind of interesting. The physiology is the same whether you're symptomatic or asymptomatic. It's just the outcome that's going to be different. People that are asymptomatic, it actually also reduces that motor neuron excitability, and in that case, it actually decreases performance because they won't be as fast, they won't be as powerful, they won't be as strong as a result of that, which is why we don't do static stretches right before we get out and do an athletic event. Also, keep in mind as a reduction in tone to the musculature related to the activity by either potentially spasm, you might get some people in spasm, but certainly in a hypertonic state as a result of increase in sympathetic stimulation, that causing muscle relaxation also changes hemodynamics, which is really important because when we are impeding appropriate hemodynamics, and sometimes we use that to our advantage, right? Blood flow restriction, but we don't want to do that forever. And constantly doing that impedes the body's ability to obviously uptake oxygen and to produce, energy metabolically through oxidative respiration, but also in removing byproducts, right? So making sure that we're really facilitating a really nice environment for healing. So just to kind of, get a sense, and so the two big guys I'm talking about, like in the lumbar spine and the hip. So it's my contention and my experience that if you're a lumbar patient, you've got some hip issues. If you're a hip patient, you've got some lumbar issues, and they kind of work together. Same thing in the cervical spine. If you're a cervical spine patient, you've got some issues in scapulothoracic and certainly vice versa. And if we think about, especially up in the cervical spine, the upper trapezius muscle, which is ginormous and an extremely forceful and powerful muscle, when it's not elevating the shoulder complex, it's depressing the head when that muscle is going to be really overactive. So we can also see that the influence of distraction. So we talked a little bit about the musculature, and one thing I failed to reiterate was the fact that in that hip we also get decompression of the hip. So in that paper by Sari et al., they also showed that there's a significant decrease in the cross-sectional area of the psoas major. Statistically speaking, they're not huge, which again, I don't like to confuse people and think that we really stretched that, but as a result of that, it tells us that we're resulting in some elongation of that tissue, which means that we're getting some relative decompression. In the central and the lateral canal, and this is actually from the same study, so basically what they do is they took people with single and multiple levels of herniations, and so they're able to show that on average, opening up the spinal canal and the lateral canal, almost 22% and almost 27%. And what we mean by that is the release of the soft tissue encroachment. So, and I like to put this a little bit in perspective too, so that when we think about, what is the diameter of that lateral canal to begin with? So in the lumbar spine, it's on average about 11 millimeters. So yeah, that's where we're only separating that by, call it 2 to 3 millimeters, which doesn't sound like a lot, but if you are an encroached nerve root or spinal cord, then that's actually quite significant, which is why this works really, really well in areas of soft tissue encroachment resulting in stenosis. Quickly, I'll go through, reducing discs and disc material. We don't see as many studies on this anymore. It's been done. It's been shown to be very effective. Couple of key components. One is to make sure that the patient is comfortable enough and they are actually creating some level of distraction or decompression. Historically, that may have been a bit of a challenge, but in today's technology, we'll talk about this a little bit. So, for example, even I know for a fact the equipment that Dr. Lallier and even the studies that you all have done is showing this effect, and so sometimes even the larger, the better or more effective it seems to be. So we see it in both the cervical as well as the lumbar. And also what's interesting is it happens at multiple levels, and it happens within just these first few minutes. So that significance, I think, is kind of interesting in that, okay, does it need to be 30 minutes? That will depend on what else it is that you're trying to accomplish. Same thing when we're looking at the amount of distraction force that's necessary, is it's not a great amount of force either. And if we think about, going back into history and, when typically people with low back pain, maybe went to a primary care practitioner and they told them bed rest, why they started to feel worse was eventually you can get into a negative discal pressure just by laying there. But again, as we kind of sometimes refer to this as more of an accelerated, rest or sleep. So that significance is fantastic in the fact that one, it doesn't take a lot of time. And two, it doesn't take a lot of force, especially with today's technology, which means that we can get to some of these probably sooner than later. And a study that came out last year, and actually two subsequent studies, they did a follow-up. It was an animal model originally, but the use of using spinal distraction actually enhanced, migration of new fibroblastic activity cells in damaged tissue. Now, it was an animal model, so that's one thing to take into consideration. And the other thing too was, that's more of an acute phase. They introduce an injury into those little rats to show that they're causing this injury. So that's a little bit different than a chronic situation where that cytokine mediated problem in the chronic conditions, that basis of rebuilding is a little bit different. So we don't see that as well. And in fact, we may not see that at all in certain patients. And several findings have showed that, does it stay? And the answer is not always, and probably not often. In fact, if you have someone with these chronic conditions. Why do we seem to improve and get better? Well, when we look at the studies back in the 1980s and 90s, when MRIs became more popular, along with decompression, and figuring out that it does tend to return. Why did we get better? Well, we also have studies that showed that 30+% of a population that's walking around that's completely asymptomatic, actually have disc herniation. So we know that do we have to get rid of it to create resolution? And the answer is probably not. But so does that mean we shouldn't do anything? And the answer is, well, we absolutely need to do something, because we need to stop that pathogenesis process from continuing to be destructive. So what it seems to be able to accomplish is halting, slowing down that process to sort of reduce the chances that it's going to be more progressive, which is still a pretty cool thing. Related to that, degeneration. And so there's a few studies looking at, well, what can we do when we have that patient? We went through that initial course of care. We seem to get them better, but it comes back either because of lifestyle, something that they did to themselves. I joke around, it's old football injury, from high school, and I didn't play football, I played soccer. So where did that come from? Well, as we age and things change, can these chronic conditions be held at bay? And the answer is that, yeah, I mean, so after a course of care, there's some opportunity that, we can actually do something sort of on that maintenance or regular basis that some of you are also familiar with in spinal mobilization and manipulation. And I've already talked about this, but so the main reason is to make sure that we halt or slow down or stop this process, least of which is reducing it from an inflammatory state to a non-inflammatory state. And that's why, if we can keep it at bay, but the opportunity during this process, and as you guys know in your program, that, this is part of, the whole system, in that what we're doing is we're capturing time here, and if we're reducing pain or improving function, it allows us to do some of those other things, not dissimilar to when you reduce knee pain in someone who has osteoarthritis. It allows them to improve the overall volume load. And I think I have some slides here at the end, and that's, what is our end game? And that is our end game, right? Is to improve human movement. And so when we can capture and we can stop some of these things in time, that's why we continue to do this, even though it's like, hey, there's still problems, and that, we know that we can intervene and make it something that's going to hang around for a period of time. ADLs, and this again goes to not having to necessarily always get imaging on people, in that we can accept the fact that performance enhancements or improvements in performance as a result of some of the changes, right? Because here's the big thing, and I was in a clinic doing it was a multiple clinic facility, and so I talk about reducing low back pain as most of us do, but the reality is that low back pain is it's a functional problem. It's not really a pain problem, right? There's something dysfunctional going on, and we need to figure out what that is so it doesn't become more progressive. We have to address the pain, right? Because if we don't, patients don't appreciate that, and they tend to be non-compliant. So statistics show the reason they come in is a dysfunctional problem. They think they come in because of pain, which is why patient satisfaction influences clinical outcomes, why we need to address that. But in any event, I like this one because they didn't really do a whole lot other than just, the decompression. It is a retrospective study, so it's a case series, but there's 778 cases. The other thing that I really like about why I sort of present this, even though it's been around for a long time, is the fact that their age range, 18 to, I believe it was 78 years old. And that's a huge range, and so without any control of some of those variables, one would think that you're not going to get positive outcomes, but they did. And the best part is, the average time of when treatment was initiated from the original introduction of pain into this patient disability was 3.5 years, right? And so that's kind of cool, and that probably resonates with a lot of us, that some of our patients came in and you're doing your initial intake and history. Why are you here? Oh, I have low back pain. When did it start? Oh, about 4 years ago. And it's like, just getting in now, and so that's the beauty of knowing that we can actually do something for these chronic conditions, and versus people thinking that they actually have to live with it. So the overreaching, aspect of this particular cohort series was looking at functionality and activities of daily living, and it's correlated with pain reduction. The reason I bring that up too is we have, we advertise, patients have a tendency, even in the literature, there's a tendency to relate this all to pain, right? But if you do, the problem is that when pain goes away, so does your patients, right? Even though they still have some dysfunction. And I often use the analogy of, I don't have to wait for my brakes to completely fail before I do something about it, or the wheels falling off the car. The irony is that by law, I have to get my cars inspected every year to make sure that they're safe to drive, but yet we let humans walk around forever, without necessarily doing something about it, when otherwise it could potentially reduce overall healthcare costs. So why is this? And this is different than the reduction of pain that you would get from a narcotic, for example. And this was my response to the question in this clinic setting that I was in. And they said, gosh, well, why bother doing this for pain when you could just, do something really easy like e-stim or something like that? The difference is that this actually gets to the dysfunctional components causing the pain. And that's where we get the correlation between pain reduction and improvement in performance, right? Because nociception, right, damage to the tissue, nociception can be blocked at the cortex by a narcotic, but we don't see that concomitant improvement in performance versus when we go to the area and we influence the painful generators that are resulting in nociception. That's why we see a concomitant improvement in performance, because we're addressing the problem. And that's a real big difference between using something that just blocks pain. And I'm a big fan. You can see some of my stuff where, mitigating pain is still important to me, but I always, always, always go for something that's also going to match up with the generation of what's causing pain. So one of the first reasons I actually got into using decompression and spinal distraction, or today's technology, over just my hands, or why I abandoned it before, was I'm like, listen, I need to be able to address and get to what I think is most important. To me, the highest order of what I do for people is manipulation, right? Because that's the one thing that actually addresses, from a neurological standpoint, I should say, is that it has ascending synapses in the cortex and then descending influence, which is very different than most other things. And it's because of, that high velocity, low amplitude, grade 5 adjustment, whatever you might call it, is a very powerful tool. And so whatever can allow me to get to that sooner than later is pretty awesome. So that was my first, sort of introduction as to why, we wanted to evaluate this, and why we looked at, some of the research on this. And again, because my earlier, patient base was not, all disc herniations. I mean, we had a lot of just neuromusculoskeletal, problems that weren't a disc herniation. So it wasn't just about, reversing that protrusion. And so we wanted to really evaluate, what can I do to get to that level at which we can be more aggressive in our approach to reduce the time frame necessary. Or, and this is what I found interesting with clinicians. I had a person in the audience one time, and he's like, well, why do I want to do that? I would make less money. And I said, well, that's a very good point. Well, one of the things that happens is, in that case, in that situation where I was starting, was my job was to get athletes back out on the field, right? And sooner than later. So job satisfaction, job security. Why would you want to do that in the clinic instead of, elongating it and having more visits? Well, when you get people sooner, better, and faster, they tend to refer more patients to you. And actually, they tend to stick around longer as I call them members of the practice. And I always tell patients, I'm like, yeah, I want to get you better and get you out of here. And then I want you to come back and see me whenever, we need to do a tune-up or you do something to yourself. I'd much rather treat you for an activity-related injury than something that is sedentary in nature. So the myoelectrical patterns, when someone is otherwise relatively healthy, they're injured, the quicker that we can get to that point, obviously dealing with the constraints of tissue healing, the better that we could be. And so one of our studies was related to this, and there's been several other studies looking at the influence of, traction on its progression. So this is one of the first studies that, I came across that sort of gave me the sense of why, we were able to be more progressive. And so this was interesting because it was a cervical spine study, but patients and people that are in pain have a decreased activity pattern to the musculature that's involved in performance. It makes sense. It's a guarding mechanism to make sure that, we can't produce too much force, power, and velocity, right? And so the downside of that is that influences your stimulus and therefore your adaptation when it comes to exercise. And I'd mentioned this just a few moments ago when we're looking at reducing knee pain actually allows people to perform a higher volume load. It's not just in their brain. I shouldn't say, it is in their brain. It's not just in their mind. It actually reduces inhibition, right? Because nociception results in inhibition. And when you address the inhibition, they can perform a higher volume load. So this has actually been shown. It allows us to be more progressive in both the cervical. Our study was done in the lumbar spine. And we've seen this again multiple times. And even when I was a younger researcher, when I was in grad school, I mean, we were some of the first people doing some of these studies looking at the electrical components with regards to this influence in motor neuron excitability and changing that particular pattern. So it's been shown in both the cervical as well as in the lumbar that we do have a pretty strong neurological influence just by doing that. We did another follow-up study, and I'll get into this when we talk a little bit about the sequencing of events. But what's interesting in patients that have nociception stimulation, when you do this on them, it reduces the nociception and actually improves their output. If you take asymptomatic people and you do that, it reduces motor neuron excitability and reduces their output, right? Which is interesting. And again, that's why we don't stretch right before an athletic event. So we found this both in the cervical and in the lumbar. And incidentally, like in this study too, I thought what was really cool or interesting was we also saw a reduction in blood pressure and resting heart rate. This is after the control too, by the way. So in other words, it definitely had an impact on the autonomic nervous system, which is, again, pretty interesting. And I think we covered all that. So just in summary, that significance is awesome because it allows us to be more proactive when you get to that rehabilitation component. And in fact, as a result of that, and you guys actually do this, right? So decompress, manipulate, mobilize, and rehabilitate, right? That sequence of events, as you probably know by now, is not an accident, right? Because when we do it in that particular sequence, so decompression actually results in a lot of biomechanical features, but from the neurological aspect, it reduces the motor neuron excitability in that hypertonicity and reduces the guarding effect. So when I go to do manipulation, we actually get an increased range of motion, and to get to that end range in that paraphysiological space, it actually requires less force, which is interesting because it decreases what it takes from me to accomplish that. So it's good for me and my longevity. It also means that we can be faster, and that's good for patients too because it reduces the adverse effects associated with manipulation therapy, which is pretty cool. We did a neat follow-up study to that too. So we even looked at, again, that specific sequence as a result of the neurological effects, and we found that even though people say, well, I thought you could reduce motor neuron excitability with manipulation or mobilization or stretching anyway. And the answer is you can, and there's a study that that actually showed the difference in the neurological bed of influence that we have in mobilization versus manipulation. And again, I talked about that a little bit ago, and Dishman and Doherty established that back in 2000 and 2001 in a couple papers that manipulation actually produces a synapse up in the cortex and then a descending pathway. that we can have that stacking influence. So what we found was, as a result of performing the mobilization first with decompression, then with manipulation, we actually got further reduction in motor activity, which was pretty interesting, specifically in that particular sequence, right? Which was pretty cool. So again, add to that the fact of what we can accomplish as a result of making it easier on me as a manual therapist, that, you know, hopefully my longevity is there, that I'm going to be able to practice for a long time. Multinodal approach. And again, this just goes to support what, you know, again, preaching to the choir, what many of us do. But the multinodal approach is it's not new, so it's been around for a couple of decades now. But for those of us that have been around longer, you know, the research was always kind of done on these one-hit wonders. They evaluated traction, they evaluated this exercise, that exercise. We didn't have the statistical power to sort of tease out the multinodal or the multimodal approach, which is doing more things. So specifically when it comes to spinal conditions, the research is pretty clear that when you perform mobilization and manipulation, you have a much more powerful outcome in all of those metrics, such as the neurological effects, the myoelectrical effects in the muscle tissue, and the influence that it has on, you know, influencing the range of motion, the biomechanics. So that's actually pretty clear in that, you know, we need to do all of these things, right? Because again, what's our end game? The end game is actually to make people move better. The problem, you know, of just doing that and just having people do exercises at home is, remember that there's an acute response to some of these things. And that's why it's important that, at least in the earlier phases of managing these conditions, that there be some introduction of the rehabilitation aspect, you know, within several minutes after we do manipulation and after we do the mobilization, right? And so this multinodal approach has been shown mostly in cervical, also in the lumbar as well. So again, really important to know that there's some overlap, but you're not being redundant when you mobilize or manipulate in conjunction with something like decompression. The other things that we're taking away from this multinodal and multimodal approach is, what does that frequency look like? So the literature is also pretty clear in that you should be doing this a minimum of 2 times a week to gain the benefits from it, to gain the long-term adaptation, the chronic benefits from that. So less than 2 weeks doesn't seem to be effective during the phases of management. That doesn't say that we can't do it once a month or once a quarter, you know, for part of that maintenance phase. And I alluded to this at the very beginning in that, you know, we implemented this also in recovery. So decompression was used in recovery in our high-end athletes to perform a lot of compressive activities like weightlifting. More specifically, this was in winter sports, Olympians for lugers, bobsledders, and the likes, to where it was part of their overall recovery program, you know, following the season. Yeah, there's also traction studies that say that traction's not that good, or decompression, or whatever you want to call it. So there are some questions you got to ask, and you know, we can go back and forth about some of the literature, and I can probably find something bad and good for pretty much everything. But it's like it's the overreaching, it's the overarching, you know, emphasis on, you know, the positive aspects, but to realize, you know, how it actually integrates within a program versus just a standalone. And that's where a lot of the negative studies actually, you know, came from. But there are some really, really good, powerful studies actually done up your way in Minnesota, at the Gertrude Lin. So that institute, in doing some of that work back in the 1970s with people that otherwise, had a lot of difficulties, and so there's some really good stuff, and there's some bad stuff. So part of it is how you implement it and integrate it within your clinic setting. So just in conclusion, I love biomechanical studies and physiological studies because they prove to us how things are working, right? And then there's the clinical studies. What exactly is it doing for us? So the biomechanical studies are very strong. I mean, we're applying mechanical energy to something, and here's what happens. We're getting a lot of benefit from the neurological aspect. We've found that the influence on discal material, allowing us for improved mobility, decreases in pain associated with this functional component, which again allows us to then do the other things like manipulation and the exercise and rehabilitation component.